John is CEO of Liberation Programs and is recognized nationally as for his domain knowledge in both addiction treatment and addiction prevention. So thanks, John, for coming back as the moderator. We really appreciate it.
My pleasure. No problem, Paul. It's great to return and have this unique opportunity to hear the latest and greatest from Dr. Souza. Consistent with the past events, such as Weed Inc., we're going to have plenty of time for questions. And to ask a question this evening, we ask you to tap the Q&A feature on the bottom of the Zoom screen. Your questions will be directly to me and not be seen by any of the other attendees. Feel free to submit your questions at any point in the program. Now I'd like to introduce our speaker. Deepak Cyril D'Souza, MD, is a professor and researcher at the Yale School of Medicine, who has conducted groundbreaking research into cannabis use and the risk for psychotic disorders, including schizophrenia. During his career, Dr. Souza has published close to 200 peer-reviewed articles and book chapters. Dr. Souza is also on the state's Medical Marijuana Program Board of Physicians. Without further delay, I welcome Deepak Cyril D'Souza.
Thank you for this very generous introduction. Let me see if I can share my screen. Do you see my screen? Okay. Can you hear me clearly? Okay.
Yes.
Yeah. All right. So thanks for the very generous introduction, and I'm going to try and spend the next 45 minutes kind of giving you an overview of cannabis use and mental health, and leave time for questions and discussion. Just a few points about disclosures. Oh, seems like. Doesn't seem to be advancing. Let me try again. No, it won't work.
Dr. D'Souza, just click on your presentation and then advance. That should work.
No. Try again. Okay, that works. So just a few things. I serve on the Physicians Advisory Board for the State of Connecticut's Medical Marijuana Program. I also receive funding from a number of NIH institutes. I have no conflicts of interest to disclose. So just to give you an overview, I'm going to talk about cannabis, how it works, the acute effects of cannabis, the chronic effects of cannabis, and spend some time talking about medical marijuana or medical cannabis. And the focus of this is really going to be about mental health and psychiatric issues. It's not going to be about medical issues or recreational cannabis. So what is cannabis? I guess most of you know what it is. There are many different kinds of cannabis plants, actually 3 different kinds of cannabis plants. But all the action in cannabis is contained in these hair-like trichomes that contain the principal active constituents of cannabis or marijuana. There is a lot that's been made about distinguishing the 2 different kinds of cannabis that people consume, cannabis sativa and indica, but it's really not clear to me that these differences are actually of any clinical significance. So you'll often hear it's only a plant, yeah, and yes, it's been around forever. And I should just mention here that so are many other plants that we know have important consequences both on physical and mental health. Cannabis contains about 500 chemicals, including more than 70 phytocannabinoids, a number of other minor cannabinoids, terpenoids, and flavonoids. So this is important for us to keep in mind as as we talk about medical marijuana later on. But the principal constituents of cannabis are delta-9 THC or delta-9 tetrahydrocannabinol. There's also some interest these days in delta-8 tetrahydrocannabinol. And then the other principal cannabinoid is cannabidiol, or better known as CBD. But as I mentioned, there are more than 70 other cannabinoids present in cannabis, but the main ones that you need to think about when you think about the effects of cannabis are THC and cannabidiol. Now, THC is the principal psychoactive constituent of cannabis. That is to say that THC is what produces all the effects that people use cannabis for recreationally, and also most of the side effects of cannabis are related to its THC content. CBD, on the other hand, or cannabidiol, does not produce any intoxicating or rewarding effects, doesn't alter perception, doesn't have cognitive impairing effects, doesn't have any cardiovascular effects. But it's received a lot of attention recently, and I know there are questions that may come up about the beneficial effects of CBD. So how does cannabis work? While THC had been identified as far back as 1963, we really didn't know how cannabis produced its effects, or how THC produced its effects, until fairly recently, and that was in 1988. And I want to spend a minute or two just talking about a little about how drugs work on the brain. So this is a cartoon of the brain, and most of the chemicals in the brain work like a key and a lock. So the lock being the receptor, the key being the neurotransmitter. Another way of showing that is you may have a receptor, and these red little triangles are neurotransmitters. The receptors bind to the neurotransmitter binds to the receptor, and that activates the receptor, and it produces a number of effects that are downstream. So we really didn't know how cannabis worked until 1988, when we discovered cannabinoid receptors. There are cannabinoid receptors that are mainly in the brain that are called CB1 receptors, and there are cannabinoid receptors mainly in the periphery called CB2 receptors. We now have the capacity to actually look at these receptors in the living human being. This is data taken from my lab at Yale, where we used a technique called positron emission tomography to look at the numbers of receptors in the brain in a living human being. And as you can see here, the high density of these receptors reflected in the red color are in those areas of the brain that are concerned with memory, cognition, motor coordination, and reward. And that is consistent with the known effects of cannabis. So when scientists discovered the cannabinoid receptors, the next logical question is, why do we have cannabinoid receptors? And by the way, animals and even insects have cannabinoid receptors. So it has nothing to do with whether one uses cannabis or not. This is a system that's present in the brain that serves an important purpose. So just as we know there's morphine, and we discovered endorphins that the brain produces, we now know that the brain also produces endocannabinoids. So endocannabinoids are to THC as endorphins are to morphine. We know that there are at least two endocannabinoids. One is called anandamide, named after the Sanskrit word meaning bliss. And the second one is 2-AG. There may be other endocannabinoids present in the brain. So I also want to point out to you that while there are almost 500 chemicals present in the cannabis plant, what some of those other chemicals present in cannabis do is very minor relative to THC and CBD. We don't fully understand what those other molecules do. So what does the endocannabinoid system do? Why do we have an endocannabinoid system? We think the system is really important in sleep, in regulating appetite, regulating metabolism. And as I've highlighted here, we believe that the endocannabinoid system is really important in neurodevelopment. And this may become more it may become more apparent to you why this is important as we talk about the potential negative consequences of cannabis in adolescence. And furthermore, we know that this endocannabinoid system is very important, also may play a very important role in inflammation. So with that preamble about the endocannabinoid system in cannabis, let's move on to the acute effects of cannabis. So when I refer to the acute effects, I'm referring to those effects of cannabis that, that are apparent almost immediately when someone consumes either cannabis, either by smoking it. Of course, when people consume oral or edibles, the effects emerge minutes to hours later. But these acute effects are the effects that most people use cannabis for. The most common reason why people use cannabis for is to experience some degree of euphoria, to feel calm and relaxed. And I'm not going to talk about the desirable reasons why people use cannabis. I'm really going to focus on, as the title of the talk suggested, the acute effects on mental health. And so what are those acute effects? But before that, I want to tell you a little about the changing landscape of cannabis. And this slide, I have to update almost every couple of months because it keeps changing. We are indeed moving towards a greener nation. As you know, Connecticut is bordered by Rhode Island, which approved recreational marijuana, Massachusetts, likewise, and most recently, New York. So in a couple of months' time, this slide might have to be changed because some new state will have approved marijuana either for medical reasons or for recreational purposes. What's also changed, and it's really important for us to keep in mind, is that the THC content of cannabis has changed. So the University of Mississippi has been tasked with measuring the content of THC in cannabis for the last actually 40 or 45 years. And just in the last 2 decades, the THC content of cannabis, and THC is, as I mentioned, the principal psychoactive constituent of cannabis. It's gone from about 4% to now to actually 12% in 2014. And it's continued to increase up to 17% in 2017. Why is this important for me to make this point? It's important because much of the data about what we know about cannabis was collected when cannabis had a THC content about 4%. So that is another way of saying that some of the data that's been collected about the negative effects of cannabis from cannabis that was much weaker than it currently is may not be relevant to to our current situation. And just as the THC content of cannabis has increased, the CBD content of cannabis in many instances has also gone down. And why this is important to keep in mind is because at least for certain kinds of effects, CBD may actually offset or counteract some of the effects of THC. So this is another way of saying that some of the forms of cannabis that we have around, for example, skunk cannabis, is more dangerous for 2 reasons. 1, it has more THC, and 2, it has much less CBD. So in addition to these, to plant cannabis, there are a number of potent products that are available, including products with interesting names like earwax and shatter, and these contain 80 to 90% THC. So just as a reminder, the THC in the 1960s, the cannabis in the 1960s had about a 4% THC. And some of these products that are available now have almost 80 to 90% THC. And the reason it's important to keep in mind is that we believe that most of the effects of cannabis are dose related, as in the amount of THC dictates what the effects are going to be. And so the higher the THC content, it would be reasonable to assume the greater the likelihood of negative consequences. So let me talk now about the acute effects of cannabis. When one smokes cannabis, the effects emerge almost immediately. when one consumes edibles, the typical onset of effects is about 60 to 90 minutes later. That's important to keep in mind because sometimes a person consumes one brownie and they don't feel any effects for 10 minutes or 20 minutes later, and they take another brownie and they don't feel any effects for another 20 minutes. And then an hour later, they've had one too many brownies. And that is not an uncommon thing. So what are the acute effects? I would broadly classify some of these acute effects as effects on cognition, including effects on memory and attention in particular, effects on decision-making and risk-taking, effects on psychomotor coordination, and in some ways, cannabis is peculiar that cannabis is thought to have biphasic effects. And what I mean by that is that at certain doses, cannabis can have anxiolytic effects, meaning it can make a person feel calm and relaxed, but it can also produce the opposite, as it can produce anxiety and panic attacks in some individuals for reasons that we don't fully understand. And then cannabis and synthetic cannabinoids like spice and K2 have also been reported to cause acute psychosis. And by that, I mean where a person loses touch with reality and may experience paranoia, hallucinations, and so on and so forth. So the implications of this are obviously the acute effects of cannabis would make it very hard for someone to engage in scholastic activities because you need to be able to attend to what's going on in the class, you need to be able to learn, and you need to be able to remember what you learned. And all these key cognitive processes are impaired acutely by cannabis. The other obvious implication is the effect on driving. We know from studies, from a number of studies, that cannabis and its constituent cannabinoids can impair several aspects of driving. We know that cannabis has been associated with higher risk of motor vehicle accidents in real world. And my lab, we do studies with looking at the effects of THC on a driving simulator. We find that people have greater trouble driving. And one area that really has not been well studied is while we know a lot about what alcohol does to driving, we know a little about what THC does to driving. We know very little about what the combination of THC and alcohol does to driving. And this is an area that I'm quite interested in, given that it's conceivable that someone may have just one drink of alcohol, which may be below the legal limit and is not known to impair driving to a significant effect. But if you combine that one drink of alcohol with just a hit of cannabis, the combination of the two may have synergistic effects that may impair driving. And it's something that we are interested in studying in my lab. And then obviously, under the acute effects of THC, it would make it hard to operate heavy machinery, and that could pose some dangers. So these are the acute effects, which typically last maybe for a couple of hours at most and go away with time. I want to talk a lot about chronic effects. And by chronic effects, I mean effects that are associated with repeated use of cannabis. And what are those chronic effects? So broadly, one might think of these chronic effects as addiction, and I'll spend some time talking about that, cognition, serious mental illness, brain structure, and hyperemesis syndrome. So very quickly, I'll talk about cognition. There is some mixed data, some studies suggesting that that with chronic use of marijuana, one can have impaired memory, attention, and even IQ. And there are other studies suggesting that after a month of abstinence, most of those effects may go away. I would say that it's not clear based on the evidence that's available right now. And furthermore, trying to extrapolate data that was collected from studies that were done at a time when cannabis had a relatively low THC content may somewhat underestimate what we should expect now with much higher potency cannabis and the availability of much of products that have very high THC content. Another peculiar syndrome that was described in the 1970s or so was this notion of an amotivational syndrome, which is not common, but is known to occur, where a person basically loses motivation. And it's often described among college kids who go to college, start smoking a lot of weed, and then drop out of classes, just really don't take care of themselves. And this has been described in the literature with chronic cannabis use. Just going back to the issue of cognition, there was a study that was done in New Zealand called the Dunedin Study, which received a lot of attention approximately 5 years ago or so. In this study, they followed everyone who was born in the county of Dunedin, starting in 1970. Everyone who was born in 1970 has been followed. And right now, but it's almost 50 years later, they have about maybe 80% of the people who were in that original sample who've been followed. And they had an opportunity to examine questions such as, if you have been exposed to cannabis in adolescence, what kinds of problems might you have? And that study suggested that those individuals who had been exposed to cannabis in adolescence performed worse on a number of tests, tests of memory, etc. They also had higher risk for schizophrenia. But what was really interesting about that study is that in those individuals who were exposed to cannabis, who stopped using cannabis in young adulthood, when they were tested at age 40, their IQ seemed to be between 6 and 9 points lower than where it should have been, suggesting that even if you stop smoking cannabis, if you were exposed during adolescence, this may lead to long-lasting changes that may be irreversible. There is quite a bit of controversy around that, but I thought it would be important to mention here. I'll talk a little about serious mental illness, including schizophrenia, bipolar disorder, major depression, and anxiety disorder. So moving on to, is cannabis addictive? I'm often asked this question. I'm often surprised by many of my colleagues who are doctors who poo-poo the idea that cannabis is addictive. So how do we define an addiction? Using the criteria that we define an addiction for, say, opioids or nicotine, for using all those criteria, we know that cannabis can be addictive. So people can use cannabis in a way that shows that they're out of control. That is, they spend too much time, money, effort, acquiring the drug, getting high on the drug, trying to quit the drug. This may impact their social, occupational functioning. They may use cannabis in risky situations, such as driving or operating heavy machinery. And then getting to the biology of it, there is tolerance that develops to cannabis over time. That is to say, if you needed just half a joint to get you high 2 years ago, now you need one joint or more than one joint as your body adapts to it, as your brain adapts to it. And what was previously recognized, we now know that there is a cannabis withdrawal syndrome, which can be quite troublesome to some people. So this is data from my lab. In the top panel, you see healthy controls, the cannabinoid receptors in their brain. And these receptors are distributed in the same brain regions that we know are associated with the effects of cannabis: memory, reward, and so on and so forth. The middle panel shows cannabis users. These are people who are using 1 to 2 joints a day. And hopefully you can see quite clearly that there is a reduction in the number of receptors in the brain of cannabis users. In our study, which was published a couple of years ago, there was about a 15% reduction in brain cannabinoid receptors. This is another biological sign that the brain, if it's continuously bombarded with cannabis, adapts and reduces the number of receptors in the brain. Fortunately, there's recovery of this with abstinence. I wanted to spend just a minute talking about the cannabis withdrawal syndrome, because until fairly recently, we didn't know very much about this cannabis withdrawal syndrome. We now know that some people experience quite a robust cannabis withdrawal syndrome. They describe this withdrawal syndrome to be almost as intense as nicotine withdrawal syndrome. But unlike opioid withdrawal syndrome, where people might die, that doesn't happen with cannabis withdrawal. The typical symptoms of cannabis withdrawal syndrome include changes in the mood. People become irritable and short, and they have trouble with sleep, and they have trouble with appetite and weight. Those seem to be the most robust symptoms of cannabis withdrawal. There are a number of other minor symptoms, but the ones that are most problematic are the effects on sleep and appetite. So when people who've been using cannabis on a regular basis try to quit, they will describe having trouble falling off to sleep and staying asleep. And this is one of the main reasons why they go back to using cannabis when they attempt to quit using cannabis. So in terms of cannabis use disorder, unfortunately, we don't have any approved treatments for cannabis use disorder. But if we have time later in this talk, I may talk about a study that we are currently doing that offers some promise in this regard. So what about cannabis and serious mental illness? I've spent a good part of the last 25 years investigating the relationship between cannabis and psychosis. And I'll talk about that in a minute. But in addition to psychosis, there is some evidence suggesting that adolescents who use cannabis may have a greater risk of developing major depression and also anxiety disorders. But in terms of serious mental illness, one of the most serious of mental illnesses is schizophrenia, which is a psychotic disorder. And there's a lot of data to support the idea that cannabis may be associated with this. This is not a newly recognized association. This was described as far back as the middle 1800s, where the French physician Moreau Dutour described, there was a club called the Hashish Club in Paris. And he described quite exquisitely, in exquisite detail, that some of the members of the club who were using cannabis developed symptoms of psychosis that in our current nosology, we would describe as acute schizophrenia. But the study that really provided the first epidemiological data that was quite substantial was from Sweden. As you know, Sweden has a draft, so all healthy young males are drafted into the Swedish military. And in that study that involved more than 50,000 people who had been drafted into the Swedish military, they found that those individuals, young males, who described using cannabis more than 50 times at the time of conscription had, in the original study, a 6-time greater risk for developing schizophrenia. That study and the data from that study has been reanalyzed in many different ways. There have been many other studies that have been done with more modern approaches, but the epidemiological studies suggest that the risk for schizophrenia is about 2 to 4 times higher in individuals who've been exposed to cannabis. Now, there are some important factors that one should be aware of. And that is, the earlier that one is exposed to cannabis, the greater the risk. That's one. And the second is that there is a clear dose response. That is, the more cannabis one is exposed to, and the more potent the form of cannabis one is exposed to, the greater the risk of schizophrenia in later life. Now, that said, what's clear is cannabis is neither necessary nor sufficient to cause schizophrenia. That is to say, not everyone who develops schizophrenia has been exposed to cannabis, and not everyone who has schizophrenia has smoked cannabis. So cannabis is neither necessary nor sufficient. We think of cannabis as being a component cause. And the analogy I would use is that of smoking and lung cancer. Not everyone who has lung cancer has smoked, And not everyone who smokes develops lung cancer. So smoking cigarettes is not necessary nor sufficient, but we know that it's a very important cause and it's one that's preventable. And so one of the reasons I'm particularly interested in cannabis and schizophrenia is that it is something that we can modify. We can't modify one's genes, at least at the present time, but we can modify some of these environmental factors. And especially as we enter this phase of liberalization of cannabis laws in our country and around the world, this is something that we really need to pay close attention to. So the risk is about 2 to 4-fold when one looks at schizophrenia. When one looks at psychotic disorders in general or psychosis phenomenon, it's probably a little higher than that. We also know from recent studies that prenatal exposure to cannabis is associated with more psychosis-like events and greater likelihood of psychopathology. As you may know, there's been about a 75% increase in pregnant women using cannabis either for recreational purposes or to treat morning sickness. And a study published just last year in the Journal of the American Medical Association showed that women who used children who were exposed to cannabis while their mothers were pregnant had a greater likelihood of having psychosis-like experiences in middle childhood, and also changes in brain structure. So one might ask, how does cannabis actually produce these effects? And this is one of the reasons why I wanted to present you something about the endocannabinoid system. The brain's endocannabinoid system seems to play a very important role in neurodevelopment. That is, the brain's endocannabinoid system, especially in adolescence and during neurodevelopment in utero, can tell neurons where they should go, which neurons should connect, and what synapses should form, what synapses should be pruned. And so one might imagine that if someone exposes themselves to cannabis during adolescence, during this critical phase of brain development, exposure to cannabis may disrupt this endocannabinoid system, which plays an important role in neurodevelopment. And that may be one way by which exposure to cannabis in adolescence can result in some of these long-lasting implications, such as schizophrenia or cognitive deficits. Now, we also know that people, once they've developed schizophrenia, tend to use cannabis. And there is very compelling evidence that once someone is diagnosed with psychosis, with schizophrenia, or even bipolar psychosis, they are more vulnerable to the effects of cannabis. So people with schizophrenia who use cannabis are more likely to end up in the hospital, more likely to end up in the emergency room, more likely to have trouble with the law, more likely to be homeless, more likely to stop taking their medication, and in general have much worse outcomes. So one important point to keep here in mind is in individuals who already have established schizophrenia, the use of cannabis is generally a very bad idea. I also say this to young kids young kids or siblings of people with schizophrenia, that if you can avoid using cannabis, that may be in some way protective. Okay, so just to summarize some of this information on cannabis and psychosis, we know from laboratory studies, and we know from drugs like Spice and K2, which are synthetic cannabinoids, that these drugs can cause acute psychosis-like effects that last for hours to days. These effects appear to be dose-dependent, meaning to say the more one is exposed to, the greater likelihood of that. We know that people with schizophrenia seem to be more vulnerable to the effects of THC and cannabis. We also know that family members of those with people with schizophrenia, and that includes siblings, are more vulnerable to the effects of THC in cannabis. There is compelling evidence that cannabis may precipitate and hasten the onset of psychosis in those who are vulnerable. And as I mentioned earlier, cannabis may be a component factor in the risk for schizophrenia, interacting with other factors such as genetic risk. So what about the effects on brain structure? There are a number of studies that have looked at the structure of the brain using MRI in cannabis users and comparing them to controls. The collective evidence suggests that people who are heavy cannabis users have a smaller hippocampus. The hippocampus is a part of the brain that is critical for learning and memory. And it's also the part of the brain that has one of the highest densities of cannabinoid receptors. So a number of brain imaging studies using MRI have suggested that individuals who use cannabis regularly and are heavy users of cannabis seem to have a smaller hippocampus. The data that I'm showing you on this slide is taken from a very important study that's ongoing called the ABCD study. It's one of the largest studies sponsored by the National Institute of Health, looking at the brain development in children and adolescents and the effects of drugs on brain development. And this was a study published approximately 2 years ago, showing that just 1 or 2 instances of exposure to cannabis was associated with changes in the brain in adolescents. This is really important. Now, these studies, brain imaging studies, they tell us about the brain as a whole, at a macro level. We now have the capacity at Yale to actually study the density of synapses in the brain. Synapses are the connections that are present in the brain. This is how the brain, the communication between the brain occurs. And we looked at the density of synapses in a part of the brain called the hippocampus, using a very sophisticated positron emission tomography approach. And we found that cannabis users, people who were using 1 to 2 joints a day, had lower levels of synapses in the hippocampus. Cannabis users shown in red, the healthy matched controls shown in blue. What was also concerning was the lower synaptic density in the hippocampus was associated with worse memory performance. As I mentioned to you, the hippocampus is really important for memory. So this is another way of saying that the lower numbers of synapses in the hippocampus in the study that we published last year was associated with worse hippocampal functioning. Okay, so I'm going to move on to the last part of this talk in the next few minutes to talk about medical cannabis or medical marijuana. As you know, medical marijuana is approved in the state of Connecticut. Right now, there are about 30 different indications for which medical cannabis has been approved. Most of those indications are for medical conditions. I am not going to talk about medical conditions. I'm going to focus this just on psychiatric conditions. So in the state of Connecticut, medical marijuana is approved for the treatment of PTSD. In a number of other states, including adjoining states, marijuana is approved for the treatment of some other psychiatric conditions, including autism, anxiety disorders, and even Alzheimer's disease. So I'm going to talk to you about the evidence for medical cannabis. So in terms of evidence, when I think about evidence, I think about anecdotal evidence and experimental evidence. The tradition in modern medicine is to base most of our decisions on experimental evidence, because experimental evidence addresses all the confounds of anecdotal evidence. And anecdotal evidence is my friend down the street smokes weed and says that it helps him with his anxiety. That would be anecdotal evidence. Experimental evidence would be double-blind, randomized, placebo-controlled study. For good or for bad, modern medicine relies on experimental evidence. And so what is the experimental evidence supporting the use of cannabis in the treatment of psychiatric conditions? So we have studied this and published on this. I'm just giving you highlights of this review paper that we published some years ago, that at least in 2016, there was the evidence for use of medical marijuana for psychiatric conditions was very low, as in it was very low quality evidence. It would never pass the muster of the FDA review process. Likewise, more recent studies, this was published in the prestigious journal Lancet Psychiatry, also found that there was insufficient evidence for using cannabinoids, cannabis or its constituent THC, in the treatment of depression, either the disorder symptoms, anxiety disorders and symptoms, ADHD, PTSD, Tourette syndrome, or psychosis. So this was a very comprehensive review, meta-analysis looking at all the data between 1980 and 2018. So insufficient evidence. The American Psychiatric Association published a resource document. And again, I've just highlighted some of the punchline, which is that there's no scientific evidence to support the use of cannabis as an effective treatment for any psychiatric disorder. In fact, they go on to say it's more likely to exacerbate or hasten the onset of psychiatric conditions. So I think there's a consensus that there is no role for the use of cannabis in the treatment of psychiatric disorders. That said, there is some evidence to support the use of marijuana for medical conditions, just certain medical conditions. And those four that I would point out are nausea and vomiting associated with chemotherapy, neuropathic pain, spasticity associated with multiple sclerosis, and cachexia or wasting syndrome associated with HIV or AIDS. Okay, but I also want to spend a minute or two just talking about some issues that come to mind for me as a physician when we think about medical cannabis. So one issue that I'd like to point out to you is, as I mentioned to you earlier, cannabis contains 500 chemical constituents. None of the treatments or the approved medications that doctors prescribe have 500 chemical constituents. For example, Tylenol has maybe one active constituent and a number of inactive constituents. And I would argue that most of the medications we have in an armamentarium have just one or perhaps two active constituents. So in some ways, this is a paradigm shift when you think about cannabis. The other is that the tradition in modern medicine is to isolate the principal active constituent of the plant and administer that. So hopefully if you're experiencing pain and your doctor thinks it's a good idea for you to get opioids, your doctor is not going to tell you to smoke the poppy plant. They're going to give you the extracted opioid that has been produced using quality control, etc. And likewise, if you have congestive heart failure, your doctor is not going to give you the foxglove plant, but they're going to give you digitalis, which is manufactured by a pharmaceutical company. So that's another paradigm shift. There's a lot of variability in THC. There's no one THC. The THC that's probably available on the street in New Canaan would be very different from this from the cannabis that's available in New Haven, both in terms of potency. There's also significant intra and intra-individual variability. So when you buy Tylenol at CVS in New Canaan, it's pretty much the same as a Tylenol that's purchased at CVS in New Haven. That may not be the case with cannabis. We don't know simple things about dose. As a physician, with all the other medications that I prescribe, I know what the recommended dose is. We don't know very simple basic information about that. What is the dose of cannabis that one might use, for example, for multiple sclerosis? We don't have that basic information, and we really need to have that information before we recommend using cannabis as a treatment. How often should it be used, when, who assesses it, and the issue of tolerance, as I mentioned earlier. And lastly, as a physician scientist, what really perplexes me is why cannabis should work for the 30 odd conditions, at least, that are approved in the state of Connecticut. And that list continues to grow. So the point I want to make here is that there doesn't seem to be anything in common between these conditions, going from epilepsy to psoriasis to PTSD to sickle cell disease. There's nothing in common. So it makes me wonder why cannabis should work for these conditions. What may be happening is that that cannabis may be providing distress related to having these conditions. And that's a fair point, and I don't mean to dismiss that. But in terms of actually having an effect on modifying the disease, it's hard for me to see how one can justify cannabis for all these different indications. And by the way, the state of Connecticut, the list is relatively brief. In other states, it's even much more than 30 conditions. So I want to conclude. I've spoken to you about what cannabis is, what it contains, THC and mainly CBD. I've talked to you about the endocannabinoid system, and that's present in all of us, and the role that the endocannabinoid system plays. And relevant to mental illness, the endocannabinoid system plays an important role in brain development, and therefore messing with that system during critical periods of brain development, such as adolescence and prenatal and in utero, could lead to long-lasting complications. I've spoken to you about the acute effects of cannabis, acute psychiatric effects, and how that might interfere with scholastic achievement and driving and operating heavy machinery. I've spoken to you about the addiction related to cannabis and serious mental associated with cannabis. And finally, I've touched upon the fact that at least at the present time, there is no compelling evidence to justify recommending cannabis or its constituents in the treatment of psychiatric disorders. So I'm going to stop there. It's probably time to open this up for discussion. Thank you for your attention.
Thank you, Dr. D'Souza. That was an excellent presentation. Covered a lot of information, and we've already received some questions from the audience. But as a reminder, please use the Q&A button on the bottom of your Zoom screen if you want to ask a question. So many questions that we have here. And the first one comes from one of your colleagues, Dr. Kevin Severino, who wants to know, was the hippocampal synaptic density between day 1 and day 2 users and non-users affected by time since last exposure? In other words, is there recovery?
That is an excellent question that I would have expected from Dr. Severino. So the $1 million question that the study has generated for us is there recovery? And so we have a grant into the National Institute of Drug Abuse to answer exactly that question, where we would invite people who are using cannabis and scan them with this particular approach, have them quit using cannabis for 4 weeks, and then scan them again. In some of the pilot data that we've collected, Kevin, and it's a very small number of subjects, it suggests that there is some degree of recovery, but at least at 4 weeks, there wasn't full recovery. So I think we really need to do the study to be able to answer that question conclusively.
Okay, thank you, Dr. D'Souza. Next question. Given the insufficient evidence or possibly growing evidence that medical use of marijuana does not mitigate symptoms of anxiety, can you possibly predict from a shift away from utilization for generalized anxiety disorders?
So I think the effects of cannabis on anxiety are very complex. As I mentioned to you earlier, that cannabis and its constituent cannabinoids can have biphasic effects. That is, some doses it can have effects that are desirable, as in they can reduce anxiety, but for reasons that we don't fully understand, it can also generate anxiety and produce anxiety. So that's one. Second is that it also depends on the THC content of the cannabis. So there is some data suggesting that CBD or cannabidiol may have anxiolytic effects. So at least in theory, one could argue that cannabis that is very, very high in CBD and very low in THC could have anxiolytic effects. I'm not recommending that be the case. And the reason I'm not recommending that is that we do have other medications in our armamentarium that have undergone significant testing where we know the full range of side effects. Now, none of these medications, I say, are perfect medications. All medications come with side effects. But I would say that it could be problematic using cannabis to treat anxiety, because I mentioned earlier, what happens over time is that one becomes tolerant to that. And then if you try and stop using the cannabis, you might have actually rebound anxiety, or the anxiety could be worse.
Thank you. Are there specific genetic markers to determine if someone is vulnerable for psychosis, like single nucleotide polymorphisms or something?
So that's a very good question. I think that if the question is about whether we can identify those who are at risk for developing psychosis in relation to cannabis, no, we don't have that information. If the question is whether we have identified genes that might contribute to the risk of psychosis independent of cannabis, yes, we now know that there are a growing list of genes, almost 200 that have been identified, that may confer a higher risk for schizophrenia. But none of these are ready for the clinic. That is to say, I can't order a test and tell you at the end of that test, okay, your risk for schizophrenia is 10-fold or 20-fold higher than the control population. We are still not at that point. There were some studies that have not been replicated, unfortunately, suggesting that individuals with certain single nucleotide polymorphisms of certain genes were at higher risk for developing psychosis, but those have not, in relation to cannabis, but those have not been replicated.
Thank you. Another question is THC potency or age of initial use the most important determinant of a person's risk of psychotic disorder from using cannabis?
I would say that based on the current knowledge, yes, those would be the two most important factors. And they're the two most important factors also because those are modifiable factors in my book. So obviously, if you have a family history of schizophrenia, that would also be a very important factor, but there's not much we can do about that, right? What we can do is we can maybe try and convince young people to delay their first exposure to cannabis as much as possible, as late as possible, to maybe avoid that window of vulnerability.
With the higher increase of THC in marijuana or the use of THC, are we finding that the incidence of psychosis groups are going up in Connecticut? And if we can, is there any data that we can find along those lines?
So I don't think there's I don't think there's been any convincing studies that have been done, but there was a study a multinational study done in Europe, included, I think, 6 countries in Europe and Brazil. And what they did find was that there was a clear link with the frequency of cannabis use and the THC content of cannabis use. So as you might imagine, in different countries, the potency of cannabis differed, and they found a clear relationship between frequency and dose. I think that one of the, not demands, but one of the requests that I've had of the legislators in Connecticut as we talk about the legalization of cannabis is to set up a surveillance program in advance so that we can, for ourselves in our state, serving our citizens, have the kind of data that we need to advise public policy. That is, is there an increase in the number of new cases of psychosis? Is there an increase in the number of hospitalizations related to cannabis? I believe there was some data about that I heard recently, but we need to set up a program to actually do this. Yeah.
It was funny. You were talking about the all of the different diagnoses for medical marijuana, and they all seem to be unrelated. But there does seem to be a common convergence of human suffering, and it seems like there a way we can separate suffering from pain and have people have an understanding of how to treat suffering as a human condition.
Yeah, it's a great point. I mean, I think that in Connecticut they call it the palliative program. The medical marijuana program is supposed to be palliative, and I guess that captures the spirit of alleviating suffering.
Okay. CBD, everybody's talking about it. The question is two-part because I'm trying to combine questions. They're coming in left and right. Is CBD potentially helpful for treating schizophrenia? And are there any negative side effects to use of CBD that we know of?
Right. So it's a very good question. There's a lot of interest in CBD. And I think in part, a lot of the interest in CBD is because relative to THC, it is considered benign, somewhat benign. It doesn't produce psychoactive effects. You don't get high using CBD. There was a study that was done approximately 20 years ago in Germany that led to this first idea that perhaps CBD might work as an antipsychotic. There have been now about 6 studies that have been done across the world, including 2 studies done in my lab here at Yale, where we treated people with schizophrenia with CBD added on to their antipsychotic medication. And perhaps it's just my luck or my with these things, but at least in the 2 studies that we did here at Yale, there was no evidence to support the idea that THC might have beneficial effects in people with schizophrenia who were taking antipsychotic medications. There was one study done in Europe recently published in about 2 years ago in about 100 individuals with first episode psychosis. So they were very early in their illness where it suggested that CBD might have antipsychotic-like effects. To me, at least, the jury is not out. So for a drug to pass FDA muster, you have to do, you have to study many, many more patients than the studies that have been done so far with CBD. You need to study hundreds of patients to be able to say with any degree of conviction that CBD works. Those studies haven't been done as yet, but the good news is somebody is actually beginning to do those studies, and we'll have to wait for a few years to know for sure whether CBD does have an effect in the treatment of schizophrenia. Until then, I think as a psychiatrist and someone whose primary practice involves treating people with schizophrenia, I cannot recommend CBD. The other concern that I have is a lot of the CBD that's sold in the US actually has, to different degrees, some amount of THC, which could in itself be harmful. So I hope I answered that question.
Yeah.
Okay.
Another 2-part question. Can marijuana be helpful as a sleep aid and also for antidepressants?
Okay. So as a sleep aid. So one of the common reasons why people use marijuana on a regular basis is to facilitate sleep. I do studies in people who have cannabis use disorder. And when I ask them what they have the biggest trouble with when they try to quit, sleep is the biggest problem that they identify. So when they try to quit, they have a hard time sleeping. And so they have to go back to using it. The problem is if you start using cannabis on a regular basis to sleep, then it becomes a vicious cycle, because then when you try and quit, you're going to have this rebound insomnia, which is then going to force you back into use. So it's a vicious cycle. That said, there is a lot of interest in the endocannabinoid system and what that might do for sleep. And might we be able to develop other approaches to treating, harnessing the endocannabinoid system without the side effects associated with cannabis. So that's one. Second question was about THC as an antidepressant.
Correct.
I really don't think there's any data to support the use of cannabis in the treatment of depression. I think we tend to use the word depression quite loosely, but using the word depression as a psychiatrist, as in major depressive disorder, I don't think there's any data to support the idea that cannabis or THC can treat major depression. What people may be saying using the lay term depression as in, it helps me chill out, it helps relax me, it helps take the edge off. Yes, I'm sure many people, that may be one of the most important reasons why people use marijuana recreationally.
Brian Rainier from the Demas State Advisory Board wants to know, how do we get this information out broadly to the community? Do you provide any strategies for disseminating this information across all the communities in Connecticut? So,
I just like you all kindly invited me to share my thoughts. There have been other towns that have invited me to do the same. And I guess that's the only way to get to do this. It's really got to be grassroots. I'm quite sure that if towns wanted to do this, they could reach out to somebody at Yale, either myself or one of my colleagues, and we'd be happy to do it. What I did ask the legislators is, to set up educational programs for mental health clinicians and within the school system to educate our children about cannabis, about the endocannabinoid system. There's a lot of misinformation out there. And I think it's, my hope is that our legislators, if they do pass this recreational marijuana bill, will keep aside money to do exactly that, to educate clinicians and young people.
In the past, you've suggested harm reduction measures that should accompany the legalization of cannabis. Can you give us some examples of what those harm reduction measures would be?
So to me, the four issues that are most pertinent to legalization, and by the way, if I may, I've never really thought of this as an issue of legalization. To me, the issue is commercialization, right? So it's not that the states, either the state of Connecticut or other states, are saying, go and grow as much weed in your backyard and smoke as much as you want. No, that's not what we are talking about. We are talking about setting up basically an industry to sell product to you, which will generate taxes, which will help fill the coffers of our town budgets. And it's really about commercialization. That's what it's about. And it's not about legalization. I mean, there are a few countries that have done it right, like I think Ecuador, it may have been Uruguay, made cannabis legal, but there's no commercialization. You can't sell it. You can get it from the government and the idea is not to make profit. The problem I see with legalization is that there are already commercial entities, including big tobacco, that have entered the cannabis market. And they, as you know, have learned very successfully how to market products that we know can kill you, tobacco. They have armies of lawyers that have protected them. They've had lobbyists who have successfully convinced the government to protect them. They've even published research to refute the idea that tobacco smoking can cause harms. Now, these companies like Altria, which is the maker of Marlboro cigarettes, has invested billions of dollars in the cannabis market. So my concern is really about commercialization. But getting back to harm reduction, the main areas are the impact on young people and the developing brain. So what can we do to keep cannabis out of the hands of young people until they cross that threshold of adulthood? We have to limit advertising. We have to make sure these products are not sold close to schools. We have to make sure these products are not sold as gummy bears or other very, thinly veiled approaches to targeting young people. We have to make sure that there are enough restrictions in place, advertising, etc., to minimize the likelihood of young people getting their hands on this. So that's one. Second is the issue of the impact on serious mental illness. Who is going to pay for the people with psychotic disorders? Psychotic disorders are lifelong disorders. Who's going to pay for the direct and indirect costs of that? That's staggering. The other issue is driving. The impact on driving. Our colleagues in law enforcement don't have the tools to monitor, and to evaluate people who may be driving under the influence. There have been studies done in Canada looking at the economic impact of driving-related, cannabis-related driving problems, and the estimated costs ran into the billions of Canadian dollars. So when we are talking about the projected revenue from cannabis in the state of Connecticut, it probably pales into comparison when we weigh in the costs of mental health issues, driving, and so on and so forth. So that, I think I answered that.
Yeah. So there are no scientific strategies at this point to actually determine someone driving under the influence on THC marijuana?
At present, no. At present, I think that the state of Connecticut plans to train a small bunch of police officers as DREs, the drug recognition experts, I think they're called. But we really don't have any objective scientific way of determining, whether someone's under the influence, and importantly, whether that will ever stand in a court of law. Because at the end of the day, that's what's going to be, that's what's going to determine it. So we don't have that as yet. I know there are a number of companies that are looking at that, but we don't have anything as yet.
How can someone regulate the endocannabinoid system without the use of cannabis?
So that's a very good question, and that might give me an opportunity to talk about potential treatments for cannabis use disorder. So we now know a lot about the endocannabinoid system. As I mentioned to you, we know that there are receptors in the brain, and we know that there have been drugs that have been developed that can target these receptors. About 20 years ago, there was a drug that acted that was commercially available, that was an antagonist at cannabinoid CB1 receptors. And that drug was marketed to treat obesity. And it actually worked very well in the treatment of obesity. The idea being that if cannabis gives you the munchies, an anti-cannabis will take away the munchies. And so it worked quite well as an obesity drug. Unfortunately, some individuals with depression who took part in the study reported suicidal ideas. And so the drug was basically dropped from the market all over the world. But we know that there are endocannabinoids. I mentioned there are these anandamide and 2-HE. We know the enzymes that synthesize these neurotransmitters, and we know the enzymes that break these transmitters down. One such enzyme is called fatty acid amide hydrolase. And the company Pfizer, based here in Connecticut, thought that given what if they could harness the endocannabinoid system to treat pain without all the side effects of cannabis. So they developed a drug that blocked this enzyme called fatty acid amide hydrolase. They did a study in around 2005 in people with osteoarthritis who had pain and related to osteoarthritis. Unfortunately, the drug didn't really work very well in the treatment of pain. But I began to think at the time, could I treat cannabis use disorder by increasing the brain's endocannabinoids without producing the high and the psychoactive effects? And so we did a study right here in Connecticut and showed that this drug actually prevented or attenuated the cannabis withdrawal syndrome, and also reduced the amount of cannabis that people who had cannabis use disorder. That study was published in Lancet Psychiatry a couple of years ago. And now we have a very large grant from the National Institute of Drug Abuse to do a multi-center study involving Johns Hopkins, Columbia University, Yale, and the Medical University of South Carolina. We think that we have a very good biological rationale for using this approach. And we are hopeful that if this study, the subsequent study, replicates the results of the first study, we may be onto something, as a way of treating cannabis use disorder. But going back to your point, that yes, big pharma are very interested in developing drugs that can target the endocannabinoid system.
I had a question about, is there such a thing, and is there any data around microdosing for THC in marijuana?
Oh, there's a lot of interest in microdosing now because of psychedelics.
Yes.
But I'm not really sure it applies to cannabis. And I'd be intrigued in hearing what one might want to accomplish with microdosing.
Yeah. There's always the question of, and again, this probably is in the spirit of the harm reduction discussions. Technically, is THC in marijuana less harmful than alcohol to the brain?
So that's a very good question. I would say that, to my knowledge, there haven't been any head-on comparisons of the two. Mm-hmm. Also, as I mentioned earlier to you, that a lot of the studies that have been done on cannabis are from a time when cannabis wasn't as potent as it currently is. So it would be really hard to make that judgment. But clearly, we know that cannabis and tobacco are in the top 5 or top 10 of global disease burden. So if I were to make a guess, I would say alcohol is probably more dangerous. But I'm not so sure about the mental health consequences, obviously, other than alcoholism.
I would like to ask you questions for the next 3 hours, Dr. Souza. You were amazing and such a wealth of knowledge, but unfortunately, we've gotten through most of the questions tonight, and we are sensitive to people's time, and our time is running out. So I'd like to thank you, Dr. D'Souza, for coming, and I'd like to turn it over to Paul Reinhardt to close our program for tonight.
Thanks for inviting me.
Thanks for coming.
Thanks, John. And Dr. D'Souza, on behalf of the support group and everyone this evening, I just want to thank you for sharing your insights. This has been a true gift for all of us on the call.
Thank you.